Good afternoon, everyone, and welcome to our next installment in our Care Connect series, a webinar series we started earlier this year to help keep you informed about the latest advances in healthcare. In previous webinars, we've talked about COVID-19, how to keep your brain healthy, and the changing landscape of virtual health. Today, we are here to talk about the future of stroke care. My name is Andru, and I'm an Associate Director at VGH and UBC Hospital Foundation, and it's my pleasure to be your host today. Before we start, I'd like to acknowledge that Vancouver General Hospital sits on the ancestral, traditional, and unceded territories of the Coast Salish peoples, including the Musqueam, Squamish, and Tsleil-Waututh nations. For those of you who are not so familiar with our work, we are VGH and UBC Hospital Foundation. We are Vancouver Coastal Health's primary philanthropic partner, raising funds for specialized adult health services and research for all British Columbians. We partner with donors to support care and research at VGH, UBC Hospital, GF Strong Rehab Center, Vancouver Coastal Health Research Institute, and Vancouver Community Health Services. Throughout today's webinar, we will be asking a few poll questions to gauge your knowledge and thoughts on stroke. I apologize in advance to those who are on the phone who cannot participate. For those of you who are joining from your computer or mobile device, when the questions pop up, please select your response and we will share the results in real time. As attendees, you will be muted, but if you have any questions, type your questions into the question chat box at any time during the webcast today, and we will do our best to address each of them in the time we have. Only organizers and panelists will see your questions. This session is also being recorded and will be made available for viewing at a later time. So today we are here to talk about strokes. Strokes are one of the most common brain injuries. It happens when blood stops flowing to any part of the brain, damaging brain cells. The immediate and long-term effects of a stroke depend on the part of the brain that was impacted. We are now going to conduct our first polling question. Do you know the signs of a stroke? Take a moment to review the list of symptoms that appear on the screen and select the correct answer. Are we ready to reveal the answers? Okay, so it looks like the majority of people recognize that all of them are symptoms. So yeah, good for you on recognizing that all of these are symptoms of a stroke. So during a stroke, you may feel sudden numbness and confusion, or have trouble walking and seeing. And the most important thing to know about strokes is that time is crucial. The longer a stroke goes untreated, the higher the risk of physical disability and permanent cognitive impairment. And so at Vancouver General Hospital, we are really fortunate to have the Vancouver Stroke Program, a team of neurologists who provide highly specialized medical care for patients who've had a stroke. Whether patients are brought to VGH or another hospital in BC, they benefit from the expertise of this team through the VGH Stroke Pager, where members of this team are always on call 24/7, even right now, so hopefully they don't get called away, to provide support to all physicians all across the province. And so it's time for our second question. Do you know how many strokes take place in BC each year? So take a moment and click the correct answer, and then we'll reveal the results shortly. Okay, are we ready to show the answer? So a little more evenly spread. The correct answer is 6,500. So there's 6,500 strokes in BC every year. So as you can see, our team of stroke neurologists are very busy. And that's why I'm so grateful that they've taken the time today to share about the future of stroke care with all of us. And so with that, I will extend a very warm welcome to our speakers this afternoon. We have 3 stroke neurologists with us. Dr. Teal is the director of the Department of Neurology at Vancouver Acute, as well as a clinical professor at UBC. Dr. Sam Yip is the director of the Vancouver Stroke Program and a clinical associate professor at UBC. Dr. Thalia Field is a member of the Vancouver Stroke Program, as well as an associate professor at UBC. So like I said, all of them are stroke neurologists, and they all see patients day in and day out. So we're going to kick things off first with a short presentation by Dr. Thalia Field, who will describe some of the latest research being done here at VGH on strokes. Thank you, Dr. Field.
Thanks so much, John, and thank you for everyone for tuning in today. I'm just going to open the presentation here. It's my pleasure to speak to you all about some of the really exciting research that we're doing here at the Vancouver Stroke Program. Before we start, I just wanted to give you a quick briefer on stroke so that we're all speaking the same language, though as I can tell from John's questions, you're quite a savvy bunch already. So forgive me if this is just a review for you all. So stroke is, I'm not just biased, stroke is the most important acquired brain injury. It is the third leading cause of death across the world. It kills more women than breast cancer and more men than prostate cancer. And it is the leading cause of disability in adults and contributes to over half of dementias. There are new strokes every year, unfortunately, and as John said, there are 6,500 each year in British Columbia. However, those are just the new strokes that are happening. There's an epidemic of stroke survivors across the country, and that's nearing nearly 1 million Canadians. And it's also a very expensive condition due to both direct disability and the indirect costs of caregivers taking time off work to look after their loved ones and other impacts to the economy. It costs the Canadian healthcare system over $3.5 billion each year. So again, just to make sure we're all speaking the same language, a stroke is dysfunction of the brain that's caused by a disruption of blood flow. This can be due to blocked blood vessels, which we refer to as ischemia. So that's a lack of blood flow to the brain tissue. With a blocked vessel here, and you can see the sort of tissue injury on the right that you get as a result on the CT scan. Or it can be caused by hemorrhage, which is bleeding directly into the brain. And you can see here that there's a ruptured vessel bleeding directly into the brain tissue, and this is how it looks on a CT scan. This white stuff here is blood leaking directly into the brain. So some of you have heard the term transient ischemic attack, or TIA. And again, just so we're all on the same page, it's symptoms of ischemia, so blood flow that is disrupted and then goes back to normal. And that results in neurologic dysfunction that is there and then improves as the blood flow to the brain improves. However, it's still a neurological emergency because it can be a warning of a greater problem to come. And as you can see, this is a very common cause of TIA. It's a very dangerous cause of stroke. This is plaque in the carotid artery, and maybe a tiny little piece is broken off, causing symptoms that are there and then go away. But the underlying problem is still there and could still cause issues. So it's very important to continue to seek medical attention, even if those symptoms have gone away. So the tenet of treating acute stroke is that time is brain. The brain is exquisitely sensitive to changes in blood flow and disruption of oxygen. And for each minute, we can lose up to 2 million neurons. So we try to institute treatment for acute stroke as quickly as possible. We know that we need to act really fast because for every 30-minute delay that it takes to restore blood flow to the brain, the likelihood of having a good functional outcome, so going home, being independent in your activities of daily living, decreases by about 10%. So as we've established, you all are very familiar with the many different ways that stroke can manifest. The reason that the public education campaigns have focused so much on what we call FAST, so face and arms and speech and language and the time sensitivity of the issue, is because this is where the majority of real estate occurs. This is a map of the brain, so this is kind of a cross-section if I were to slice right through. And this is where the different parts of the body kind of map onto the brain in terms of function. And as you can see, arm and face and language and the kind of organs that contribute to language take up a big piece of real estate. So there are other symptoms that stroke can manifest with, but these symptoms are the most common. And certainly, again, treatment is time sensitive because faster treatment is associated with better outcomes. So we are very busy, as John said, at Vancouver General Hospital. We see over 2,000 acute stroke assessments per year. We treat more than 250 patients with endovascular therapy, so going directly into a blood vessel and pulling out the blood clot. And we also have a diversion program. So people in the Lower Mainland with the most serious stroke symptoms are taken directly from the community by paramedics straight to VGH instead of stopping at their local hospital, just because the expertise and the resources are concentrated here. We also take patients with complex cases from across the province, and this is just a picture of a helicopter joining us on the landing pad as we're preparing to receive a patient from northern BC for delivery of acute stroke therapy. So research is a big part of what we do at Vancouver General, and it's with the aim of improving care for all British Columbians with stroke. We are participating at any given time in a number of trials. Right now, there are about 18 that we're currently participating in, and they take place at all the steps along the patient journey with stroke. So if you think about what would happen if someone comes in with acute stroke symptoms from, the time that, you call the ambulance all the way to the time that you're back in the community, there are several different phases where we think about where stroke research is taking place. We're also well connected with the national and international groups of researchers that are aiming across the world to improve stroke care. This is just one international conference where we were talking about standards for acute stroke treatment. You can see the short little person holding the Canadian flag in the front is me. We're involved not just with acute stroke treatment, but all sorts of different types of stroke at all the stages along the patient journey. So what are the steps that we're considering when we think about how we conceptualize stroke research, and how does that affect the sort of research that we're doing? Well, again, in treating acute stroke, the first most important step is trying to save brain. And part of that includes treating patients as quickly as possible. And then part of it is seeing how we can augment that saving brain as much as we can. So, number one, how can we get arteries open better? We are testing new clot busting drugs. We have the older one, tissues plasminogen activator, and then kind of an old one that's being considered in a new context in different doses called tenecteplase, which may be better at opening up arteries. We're considering different therapies and different techniques for opening up blood vessels, like whether or not we need to do stents or whether or not we just kind of go and angioplasty and balloon the arteries open. And we're also looking at neuroprotective drugs. Are there any medications that we can give to kind of help the brain hang on for a little bit longer when it's deprived of blood or oxygen? With regards to hemorrhage, it's a more difficult problem to treat, but we're right at the front of helping to discover new therapies, such as testing new agents to promote clotting in the context of bleeding, and also looking at how we can deliver treatment as quickly as possible in the ultra early setting. So looking at some treatments that may have been tested before, but delivering them as fast as we possibly can. So one treatment course that I mentioned is neuroprotective therapy, and we were recently involved in a very big international study looking at a novel neuroprotective agent to help protect the brain during these problems where blood flow is being disrupted. Why do we have to keep pushing for saving brain tissue when we have other treatments that sometimes help to preserve brain? Well, the truth is that these treatments are good, but they're not perfect. So this is the difference in kind of survival and disability that has been demonstrated by opening the blood vessels directly through endovascular therapy. So you can see this is what the burden of death and disability were previously for every 10 people that had an acute stroke. And this is how endovascular therapy has changed that. However, we still have a long way to go. And for patients where there's any amount of brain damage, we have to consider whether there's a way to preserve that brain tissue by giving medications that kind of slow that process of brain death. So one agent that we're testing is something called NA1, and it prevents that cell death process, and we're testing it in two important settings. One is pre-hospital, so getting it to patients as fast as possible before we've even diagnosed the type of stroke they may be having. And the other context is in the angio suite, so delivering that drug even before the artery is open. Another thing that we're doing for research, which may not seem that glamorous, but it's extremely important, is trying to find ways that we can all work together as a team to deliver treatment as quickly as possible. As I mentioned, for every 30-minute delay, there's a 10% decrease in the chance of an excellent outcome. And Dr. Yip has been working with the stroke team in order to perfect stroke simulation strategies. And one of our trainees and one of our future stroke neurologists, Alison Pokash, has gotten some competitive funding in order to look to see if we can parlay those techniques to other people that may be treating stroke in the community, such as internal medicine physicians and emergency medicine physicians. So what's step two? So people after they've had a stroke can be at risk for subsequent strokes, particularly early on after the process. So we're always looking at the best possible techniques in order to prevent that from becoming an even bigger problem. So what are we looking at? We're looking at a number of different drugs. There are older drugs in newer settings. For example, on the upper left-hand corner here, this is a scan of inflammation in the carotid artery. I showed you before that the carotid artery can be a cause of major stroke, and sometimes it can present with more minor events like a TIA. One thing that we're looking at is actually an old gout medication, which has been shown to prevent inflammation in the blood vessels in people with heart attack. And we're part of a big international study looking at that with stroke. We're also looking at some of the newer blood thinners for tough problems to treat for stroke prevention, such as intracranial atherosclerosis, which is narrowing of a blood vessel here. That's a cause of major risk of recurrence for stroke. We're looking at different ways of conceptualizing stroke treatment in terms of strokes that may or may not come from the heart. Should we just be looking at abnormal heart rhythms as a reason why we might change our blood thinning treatment, or should we also look at the structure of pieces of the heart like the left atrial appendage? And then this is just one example of a brand new blood thinner that we're testing for stroke prevention called a factor 11A inhibitor. Okay, 1 second. Just going to ask my husband to stop ruffling through the doors and making that much noise. Noise canceling headphones, it's the future. Okay, so next step is trying to figure out those outcomes that are most important to patients, because we can look at things like having recurrent strokes, major levels of disability, but often it's the important things that patients come to tell us about that we haven't even known in the past that we should be looking at. Things like minor issues with cognition, difficulties with pain and mood and fatigue, problems with their relationships with their family. All of these things are things that are extremely important to patients and in turn are very important to us, but it's difficult to know unless we're able to consult with patients as partners in the research process. Above, we have a poster that was done as part of a patient research forum relating to cerebral venous thrombosis, which is a rare cause of stroke, and that's part of a trial that I'm running across the country. And just listening to outcomes that patients have been telling us about have been most impactful to their life. Again, it's not just the patients that stroke affects, it's their family members and their other loved ones as well. And part of the great thing about this patient forum is that we were able to have patients' supporters come with them as well in order to give us some feedback from an observer's perspective as to how symptoms were affecting the recovery process. There are some things that can be more difficult to manage if you're a higher functioning stroke survivor. For example, you may have very minor cognitive issues after stroke, but if you're high functioning or you're well educated, you may do very well on the types of cognitive screens that we would normally give to look for minor cognitive problems. So we're also investigating kind of state-of-the-art ways in which we can pick up and check the pathway for subtle cognitive problems, for example, through something called natural language processing, which is an artificial intelligence intelligence-mediated analysis of speech and language. One study, we're looking at whether if we have patients wear an Apple Watch and the Apple Watch kind of buzzes every couple of months to ask a patient a question about how you're doing, whether we can have an automated analysis of that speech and how that will correlate with their cognitive scores. So, a next important step is that we're not just delivering the best care to people as they're coming through the doors of Vancouver General, but also our responsibility as a comprehensive stroke center to distribute the best possible stroke care across the province, and how that can be parlayed into lessons that we can take across the country. So one thing that we're looking at expanding in terms of a research tool is something called Telestroke, and we'll have a chance to tell you a little bit more about this technology later. But one thing that we can do is connect with patients via cameras in different hospitals or even in their homes from across the province. And how can we use that not just as a tool to deliver treatment, but also as a tool to do research assessments and engage people from across the province that can't come directly to Vancouver in order to help them access important research to improve their care. Another thing we've looked at is a simpler intervention. This is a picture of our lead research coordinator, Karina Villaluna, and she is doing a study where we're looking at-home blood pressure management via simple things like phone calls to patients and family members. And this is just some preliminary data from the study, and basically what it shows is a decrease in blood pressure over time. And in our preliminary studies, we've been able to show that through this very simple intervention in 12 weeks, we can get blood pressure controlled in many patients just through these phone calls with patients, or if there are any cognitive issues, their family members. Other more state-of-the-art ways in which we're trying to improve care on a wider basis include collaborations with colleagues that are looking at other types of machine learning in order to determine optimal transfer logistics. For example, let's say the weather is really bad up north, but we have to get a patient down to Vancouver General to give them treatment. What's the timing, and how can we decide where the patient should go in terms of getting a clot-busting drug, and how long can it take them to get back down to Vancouver General before that treatment may be less helpful due to delays. So lots of interesting things that we're looking at, and again, with the main goal of improving care for everyone with stroke. And that brings me to what I would call step zero. So preventing strokes so that they don't happen in the first place. So one thing that we're trying to do is figure out, why people are at risk and how we can kind of improve preventative strategies for everyone. These are just examples of the main risk factors that people can have that can put them at higher risk for stroke. And these don't necessarily apply just to older people, but they can affect younger people as well. So sometimes there can be changes in the brain that happen before people even present with strokes, and they may be warnings of greater problems to come, and that can help us focus on how we can kind of tailor preventative strategies in order to help people that are most at risk. So on the left, these are just examples of silent brain changes that can accumulate over time. And these are rates that occur in the general population for kind of these silent brain changes. And as you can see, it's associated with age. As you get older, you're more at risk for silent brain changes, but these can also happen in young people as well. And in particular, people who have had issues related to social deprivation, difficult upbringings, poor nutrition, lower socioeconomic status, are at even greater risk for poorer health in a number of arenas, and that extends to brain health as well. We've been involved with a study looking at people living on Vancouver's downtown east side and looking at how changes in their brains tend to be accelerated despite being at a younger age, and how this can tell us about what we can do in terms of tailored brain prevention strategies for people who are more at risk. Another really interesting technique that we're looking at is kind of this back to artificial intelligence, multimodal analysis of speech and eye movements at the same time, and to see how that might actually foretell silent changes that are occurring in the brain and help us to identify people who may be at risk before they may even have a stroke. So lots of really exciting things happening in terms of kind of that tailored population for prevention. So here's more good news, and that good news is that research does make a difference in improving care, and that in Canada in particular, as leaders in stroke research and stroke care, those changes have been pronounced over the years. So we know that even though the absolute number of people with stroke is increasing as our population ages, that the rates of death and disability are lower. So these are 10-year trends in rates of death due to stroke. This is leaving off in 2012, but I can tell you that the numbers have continued to go down from there. This is another graph just demonstrating the dramatic effects that preventative research has had on stroke recurrence. So the blue line up here are rates of stroke recurrence from year to year after you've had a first stroke back in the 80s. You can see even 10 years ago how much dramatically lower those rates of recurrence were due to a number of innovations, many of which were Canadian innovations and tested in centers across the country, including here at Vancouver General. Things like carotid endarterectomy, so surgery for carotid plaque, studies looking at blood thinning for atrial fibrillation, which is an irregular heart rhythm that can put people at increased risk for stroke, blood vessel imaging as a way to triage people at higher risk for stroke and stroke recurrence, looking at different blood pressure targets and extended cardiac rhythm monitoring. So we've been very pleased to contribute to a lot of these innovations that have helped to improve stroke care already. So research is just one small piece of our greater effort. It takes a number of people from our our on-the-ground research staff, our nurses, our allied health professionals, our team members, our trainees, our neurointerventionalists, and again, the central role of patients and families in helping us move research forward. And again, just as a piece of pushing the boundaries of care in general for people with stroke at Vancouver General and in BC in general. We are focusing on a number of initiatives to improve clinical care and quality improvement. And also education is a big piece of what we do. We aim to train the stroke neurologists of tomorrow through our fellowship program. And also we aim to help educate the public to further help with our prevention efforts. And again, thank you for being part of one of these today. So with that, I will be happy to share your questions with my colleagues, and I'll leave it to John. So I'm just going to stop sharing my screen here and go from there.
Thank you so much, Dr. Field, for sharing that overview of research. And it's really great to see that there's so much work that's going into understanding, finding better ways to treat stroke, to prevent strokes, improve quality of life and rehabilitation afterwards. So I think it's great to see that there's progress being made and on all of those fronts. And so now we're going to jump into our Q&A time. And so a number of you have already submitted questions, so we'll get to that in a second. Please feel free to submit questions through the question chat box. Please do keep questions as broad as possible and focused on the topic of stroke. We'll try to avoid any sort of very specific and personal medical questions, just so that we can ask some questions that will be of interest to everyone on this call. So my first question is for Dr. Sam Yip. It would be a little strange not to acknowledge the elephant in the room that has defined 2020. COVID-19. So Dr. Yip, can you tell us, what do we currently know about how COVID impacts the brain in the short term and long term, and whether or how that might be connected to strokes?
So, as the COVID pandemic progresses, reports of neurological manifestation of COVID has increased. I think in the past 6 months, there are about more than 1,000 cases or group of patients have been reported to have suffer neurological disease from COVID-19, and these are very serious neurological manifestation. The most common type is what we call encephalopathy, which is a general term describing the disease affecting the function of the brain and manifesting as a change in personality, behavior, cognition, and decreased level of consciousness. Some patients with severe encephalopathy may result coming with coma. Okay? Now, the second most common presentation is actually stroke. It is believed that approximately 2% of all COVID patients are admitted to hospital have severe strokes, and they affect young patients and also elderly patients with traditional risk factors such as high blood pressure, diabetes, high cholesterol, smoking. And there are some series that came out from Europe, mainly Paris, looking at COVID-related stroke, and it showed that patients with COVID-related stroke tend to have poor outcome, even when we use our traditional treatment that Dr. Field has talked about. And it's unclear as to what's the reason, but there have been some early clinical experience suggesting that using an older blood thinner called heparin may reduce the severity of these strokes, and there are currently some clinical trials, ongoing clinical trials across internationally to look at the effect of heparin on COVID-related stroke. Now, I mean, there are a whole bunch of other neurological conditions that can be due to COVID, direct infection of the brain, such as meningitis or encephalitis. It can also affect the peripheral nerves, causing neuropathy, and it can also affect the muscles. So every part of the nervous system can be affected by COVID-19. And unfortunately, we don't have any long-term data of what the outcome is in these group of patients. And so there is actually a consortium built, now recently to look at the long-term effects of these patients with COVID. I mean, we are very lucky. I have to knock on the wood that in BC we have been fairly lucky in that we don't have a lot of too many COVID cases and patients affected with neurological presentation. And we've got phone calls from or pictures or CT scans from some of our fellows that who were trained here and have now moved back to Spain or in other parts of Canada, sending pictures to us, asking us what we could do. And I told them, well, you guys are now the experts because you guys are seeing more cases than we do. So, but we're all learning from each other. We have a very good international network. So hopefully it wouldn't happen in BC. But if it happens in BC, we'll probably have a lot of experience to figure out what to do in these patients.
Great, thank you, Dr. Yip. I just want to turn to the topic of prevention. So Dr. Phil Teal, can you tell us a little bit about what we can be doing as individuals to prevent the strokes from happening in the first place? Where should we be focusing our prevention efforts?
Right. Well, we are making incremental improvements in stroke prevention on dealing with risk factors, identifying patients at high risk for stroke, and targeting patients who have TIAs, which provides us with a unique opportunity to intervene in a very timely fashion. Most of the improvement in stroke prevention will come from just doing things better that we already know works. For example, the reason we actually treat hypertension on a population basis is to reduce the risk of stroke. And most people don't appreciate the link between hypertension and stroke, but the brain is the target organ for hypertension. And it's estimated if we could reduce the blood pressure of the population by 2 points, systolic blood pressure, we could reduce the overall risk of stroke by perhaps 15%. So simply identifying simple vascular risk factors and treating them optimally, atrial fibrillation, smoking cessation, elevated cholesterol, identifying patients with high-grade carotid stenosis, atrial fibrillation. We've got treatments for all of these things. If we could identify patients with these risk factors and optimally treat them, we could probably prevent up to half of the strokes that we're currently seeing. So it's a highly preventable condition. But a lot of it is also organized stroke care, TIA clinics. So we run a TIA clinic just down the hallway from me, 5 days a week, multiple clinics a day. And the goal for that is to see patients in a very rapid fashion who've had a TIA, warning of a stroke that Dr. Field mentioned about. These patients are at risk for very early stroke within the next few days, next week. And if we can get them in a timely fashion, get them on the optimal treatments that we already have, antiplatelet drugs, blood thinners, early access to surgery, identification of the atrial fibrillation, we can prevent those strokes. So that's another method of preventing strokes. Another way, which we're doing better now, is public information, public awareness. The FAST campaign has been hugely successful, and it's on a weekly basis where a patient or a family member will have identified that their spouse, their relative, or somebody in the store has had a stroke, and they'll do show me your face, speak, hands up, that sort of thing. So public awareness is a huge thing, and that identifies patients with both TIAs, which gives us time to intervene and prevent stroke, but also the patients who are truly having a stroke. It gets them to the hospital sooner so that we can get these acute treatments going while we can still salvage brain. Now, a lot of the rest of it is going to be incremental changes through improvements in organized stroke care, making sure that patients can, that we can see patients, not just at Vancouver General, but rural and remote. And we'll come to that in the telestroke section, I think, which we'll talk about later. If we can see people in a timely fashion, even if they live, in northern BC somewhere in a remote community, we can still help them out and get them access to care. So I think public awareness, TIA clinics, optimal use of known preventative strategies with agents that we already have should reduce our risk of stroke substantially.
Great, thank you, Dr. Teal. On that, you spoke sort of about the symptoms and how we identify strokes, quickly and get people to the hospital as quickly as possible. Dr. Field, can you tell us, if someone around us or a family member experiences a stroke, what should we be doing, or is there anything that we should be doing while we wait for the ambulance? Should we be taking the person directly to the hospital? What do they actually do inside the ambulance while they're going to the hospital? Can you tell us a bit more about that?
Thanks, John. Yeah, I'd be happy to. Certainly, we tell people to call 911 just because the paramedics have a direct pathway to the emergency room here in Vancouver General or to the other major stroke centers in terms of letting the stroke team know that the patient is coming. And that way we are prepared. The patient is registered and in our system already so that scans and other treatments can happen as fast as is possible. Some people tell me, well, my husband's a really fast driver. I think, he'd be okay. That's great. But I mean, he doesn't have an ambulance that has a direct patch to our triage. And that way we can multitask. And we're waiting for you when you come in through the door. So again, the most important thing to do is to call 911. The other thing that's very helpful is if you actually specifically state your concern that someone is having a stroke, that also helps the paramedic triage dispatcher determine that a certain group will go with special expertise and that Vancouver General can be waiting. They've actually looked at interesting ways with kind of artificial intelligence to tease out symptoms that people might be talking about to detect stroke for this precise reason, because again, time is everything. The other thing that it's important to do, of course, is to make sure that your loved one is safe. So, if they have a depressed level of consciousness, if they seem comatose, to make sure that they're breathing safely, to make sure if they're vomiting that they're not at risk of choking, if they're by the stove, to make sure that they're not getting burned. So really to focus on safety after you've called the ambulance. Those are the most important things. Sometimes people say that they've taken aspirin or another blood thinner in advance. And, I think there's been a lot of education around that for heart attacks, but because of, as I've spoken about, people can have strokes due to blockage of blood flow within the brain from ischemia or due to hemorrhage, bleeding within the brain. We don't recommend aspirin on a wide basis just because it is possible that it could make bleeding in the brain worse, and it can be difficult to diagnose that without a dedicated brain scan. So you asked about what people are doing when they're actually in the ambulance. So they're assessing patients, they're making sure that they're breathing safely, they're making sure that they're communicating the information to the stroke team through the hospital as fast as possible. And in some cases, they're participating in that research trial I was talking about where they're giving that neuroprotective drug or placebo to patients who may be having stroke symptoms. So the involvement in paramedics in new research strategies strategies has been something that I think is quite groundbreaking and very important, I think, in order to test the importance of early delivery of some of these stroke treatments.
Thank you, Dr. Field. Kind of following on that, you talked about sort of research kind of happening, starting right in the ambulance. Dr. Yip, how does one sign up for? Do you sign up for stroke research, or how does that work? Or do you approach the patient, or do I put my hand up and say yes?
Yeah. So, and well, we kind of get our patients involved in many different scenarios. Majority of them is when we have our clinical interactions with our patients. We identify the patients as having certain disease, and then we have 18 trials ongoing. So we often have to actually call our research nurse and try to figure out what's the include, because these trials are fairly complex and a lot of times have different inclusion exclusion criteria. So we have a research nurse that are assigned to learn and know all about these clinical trials down to details of all the details. So basically, we would identify these cases, and then we'll let our research nurse know. First ask our patient whether they would want to be included in the clinical trial. We offer that as an option, and then if they're interested, then we'll get the research nurse to make sure that they're appropriate candidate, then they'll go into ask them to approach them and consent them. And therefore we have, because of the 18 trials that we have like a huge support from we have about 3 research nurses and then a number of research students as well. So that program has grown significantly over the past few years.
Thank you, Dr. Yip. So as I think we alluded to this already about how, even though it's called the VGH Stroke Program, the Vancouver Stroke Program, there are sort of the connections to people all over the province, regardless of where they live. Dr. Teal, can you tell us a little bit about telestroke and how the program is able to care for people around the province? What is it, and why does it matter?
Sure. So telestroke is a way of providing distant care to patients who either live in Metro Vancouver. So I'll talk about our sites that we support in Metro Vancouver, but more importantly, to provide outreach care to individuals and people in rural and remote sites. Some of the hospitals we serve in Northern Health, for example, these are like very small hospitals, 15 or 20 beds, with very limited resources and not a lot of stroke experience because they simply don't see them. So telehealth, we started many years ago with fixed video links, working much like this, face-to-face with a fixed camera in an emergency department where we can interview the patient, move the camera to the spouse, to the emergency physician, up to the monitors. We can actually do an acute stroke assessment in a distant hospital for purposes of making the diagnosis, clarifying the treatment, recommending the use of clot-busting drugs, TPA, and so on, and also activating life or limb transfers by a variety of systems. So that's the ideal sort of use of telehealth, but of course it's morphed very rapidly. Currently, we're serving with fixed cameras in the ER, Peace Arch Hospital, Chilliwack Hospital, Sechelt, Powell River, and Smithers, soon moving into Prince George and other areas in the north. And that's with direct video links like this, but we do all sorts of other telehealth support. We do telehealth through our stroke prevention clinic using Zoom, FaceTime, whatever means possible. Everything tends to start with a phone call, sort of old school telehealth. So we do it for stroke prevention. We do it for acute stroke therapy. And it's an extremely effective way and surprisingly an intimate relationship that you develop with the patient in an emergency department with an acute stroke. Within a minute, they're engaged with you, the family's engaged with you, and it's just like talking on this sort of screen, but we can do a competent neurologic exam and recommend treatment and transfer. So that is the future of providing acute stroke care and stroke prevention strategies to this huge geographic province that we've got with transportation issues and weather issues and climate and variable resources. So this really has been a huge asset for us and provides better health care for all of our citizens.
Thank you, Dr. Teal. Dr. Field, in your presentation, you touched briefly on, we know that there's the two different kinds of stroke, ischemic and hemorrhagic. Can you speak just a little bit more about sort of research on hemorrhagic stroke and sort of where are the best sort of opportunities to try to improve the outcomes from hemorrhagic stroke that you know of?
Yeah, thanks so much, John. Hemorrhagic stroke, as I've said, is one of the bigger challenges to treat in the realm of stroke research. I think there have been a number of really interesting initiatives that are very important over the last couple of years. I think the first is establishing an international research effort with kind of dedicated ways in which we ask questions in a standardized manner so that we can share data and combine it to get the best answers as quickly as possible. So we've been part of those efforts. One thing that we're looking at are ways to promote clotting. So this is something that's been tested in the past, but maybe in patients that might not have been the best candidates. So we know more than ever that early treatment is critical. And I think we have the resources in the organization to deliver early treatment trials now more than ever. So one trial that I'm very excited that we're about to start looks at one of these treatments that promotes clotting, again, in that ultra early setting, just as the patient is hitting our front doors. Another thing that we're looking at are novel blood thinner reversal agents. So that's another trial that we're participating in. And then other techniques include ultra early strategies for lowering blood pressure and identifying those candidates even before they've had a brain scan as to how that might happen. We've talked about kind of novel ways to identify patients that may be at risk. So ways to kind of look to see based on subtle changes what might be going on in their brain that might demonstrate a risk marker. So those patients can be identified for future genetic studies or targeted pharmacological strategies for lowering blood pressure and other strategies to kind of reduce the burden of what's called microbleeds. So these teeny tiny little warning signs that can occur in patients with hemorrhage. And also we've been kind of conceptualizing the rehabilitation trajectory separately in patients with hemorrhage. One thing that we've kind of said in acute stroke trials is, well, it's important to know how the patient's doing at 90 days, but we're learning that with patients that have had hemorrhagic stroke, that trajectory of improvement is actually much longer. So even the simple act of following patients for longer and kind of targeting a different time frame in terms of rehabilitation is important. And just finally, there have been some interesting surgical trials that have occurred previously, looking at kind of taking bleeds out of the brain with special surgery. For all comers, that hasn't been helpful, but more recently, they're looking at very specific surgical techniques where you can actually put a catheter directly into the body of the blood clot, kind of later on after hemorrhagic stroke has occurred. While it's not a universally helpful treatment that we don't do routinely because it's very difficult to do that catheter placement, treatments tend to improve over time, and we look forward to participating in any future studies that are trying out that technique. So just a few examples of treatments on the horizon that are being tested.
Thank you so much for that, Dr. Field. My next question is for Dr. Yip on that subject of stroke rehab. What sort of resources might exist for, or, what would you point to patients to after having a stroke? Are there, things that they can be doing, should be doing, is there a checklist of things to do? Can you speak a little bit to kind of post-stroke?
So for post-stroke, a lot of times, depending on the degree or the severity of the stroke itself, oftentimes they're in hospital, we will have assessment with our rehabilitation consultant, our physiatrist at either GF Strong or Holy Family Hospital to assess the patient and see what kind of rehabilitation they need. And And even as an outpatient, oftentimes we'll also refer these patients for outpatient rehabilitation. But oftentimes what I found is that a lot of patients will go through the rehabilitation, but eventually over time, their symptoms may return because they stop doing the rehab that they're supposed to carry on once they leave the hospital or once they leave the rehab situation. So rehab facility. So what happened is I usually refer them to physiotherapy, occupational therapy. Oftentimes there are some rehabilitation or physiotherapists out in the community that specifically do stroke rehab. And then there are also a number of different community rehabilitation program. There's one that's called Time. I think it's over at YMCA, as well as other community centers that people can look into. So there is also a stroke recovery group that they can also participate in, and that's the BC Stroke Recovery Group. So there are a variety of different ways of getting back to doing rehab, but majority of it is actually usually when the physiatry discharge the patient from the rehab, they use sets of exercise. And people tend to think that they have to do the exercise in a rehab facility with a physiotherapist or with, in that setting. But a lot of these exercises can actually be done at home. So it's simply asking the patients to, remember those exercises that they assign you to do, just start doing them. You don't have to, like going to rehab means, doing the rehabilitation, but not actually going to a rehab facility. You can do the, do the exercise anywhere, even at home, right?
Great, thank you, Dr. Yip. And on that note, I think we're out of time. I know we didn't get to all of the questions that were posed by our audience, but we'll see what we can do. I do really want to say thank you to Dr. Field, Dr. Teal, Dr. Yip. Thank you so much for taking the time today to share with us your knowledge and your expertise. And here at VGH UBC Hospital Foundation, our goal is to enable our healthcare partners to provide the best care possible. And we do that by supporting the purchase of critical equipment, funding high impact research projects, some of which you heard described today, and helping to recruit and train the next generation of specialists and fellows. And the Vancouver Stroke Program is one of our foundation's top fundraising priorities, and we do invite you to consider making a gift, or if you've already made a gift, to please continue your support for the Vancouver Stroke Program. You've heard today directly from the beneficiaries of your support and how your donations are helping to advance the future of stroke care here in BC. And in particular, I do want to thank our donors who are on the call today, who have supported the Vancouver Stroke Program over the years. You can learn more about our work to support brain health and care for a variety of conditions and diseases beyond stroke. So that includes whether it's Alzheimer's, epilepsy, concussion. I encourage you to visit our fundraising campaign webpage. That's www.brainbreakthroughs.ca. And following the webinar, you'll receive a short survey. So please do take a moment to provide us with your feedback and your ideas for future topics. And just want to say thank you again to our panelists, and thank you to our audience. And I hope you learned something new today. And that's it. So thank you.